Thank you for joining us today. We'll be discussing the precision health at University of Michigan. And what we're learning about today is what the initiative is, what the initiative isn't, and how you can get involved in precision health. We'll be going over several elements of the initiative, including specific work streams, the goals of those work streams, the science that we're trying to encourage, and all the different individuals that are already providing insight into how we can improve the health of Michigan communities. Thank you for coming. So happy that you're here. We know this is early, but by med school standards, this is just a little bit early. We tried to have different times for different campuses, and we'll probably have a couple more communications like this at different times as well. My name is Sachin Kheterpal. I am one of the co-directors of the 3 co-directors. We're going to go over essentially overview of precision health. We're going to have one faculty presentation by Jenna from the College of Engineering. She's a spectacular colleague in this area and really showing the power of what we could be doing at U of M when we go outside individual siloed colleges and schools. And then there is an information card, if you don't mind filling that out. One key thing we're trying to focus on over the next little bit here is just maintaining the communications. Communicating what this thing is, what this thing isn't. Getting feedback from you is one of the most important things we have as our goal right now. So please, that feedback card and the communications that we can generate by having your email address. We will not spam you. You can always unsubscribe. We're being very cautious and careful about that, but we would appreciate that card getting filled out. And there's also a handout at the beginning of this whole thing. If you saw when you walked in right by the breakfast area, that handout does also summarize some of the materials here. I'd like to, before we get fully started, just introduce a few people that are here from our precision health team. Some of them are still outside for a moment, but I'm Sachin Kheterpal, co-director. We've got Rachel Dawson, who's the managing director in the back there. Rachel makes things happen. As I oftentimes say, faculty are necessary but not sufficient for progress. And she's certainly shown us the importance of that concept. I believe Tina is still outside. Tina Krazier, you may have met her outside. She's a senior project manager, also taking our ideas, your ideas, putting them into action. One of the co-directors, Gonzalo Absesis, wasn't able to join us today. He's from the School of Public Health, the chair of the Department of Biostatistics. Is Eric here today? Okay, okay. So we do have some College of Engineering timing going on there. So Eric Mickelson, one of my co-directors, is the Associate Vice President for Advanced Research Computing at the University of Michigan itself. He's a professor of computer science, electrical engineering, and he will be here in just a moment as well. And then please see any of us with questions. We will have question and answer sessions at the end, and I'll be staying over that as well. We will hold questions till the end until after Jen and I have had a chance to speak, because I think a lot of times the answers are in a couple of the slides here. So what is this thing called precision health? You are probably doing it right now. So let's be very clear. We're not here to tell you whether what you do is precision health or not. We're here to tell you, as President Slissel, the deans who've been founding schools here, what they're envisioning, an incremental investment, a new investment that we think is significant and will be causing a new phase of precision health at University of Michigan that builds upon existing work, causes new existing work. It's about taking populations of data, populations of patients, and creating new individualized decisions about individuals based upon genetic, lifestyle, environmental factors, so that we don't incorporate just one data stream. We're not just about clinical records. We're not just about the genetic stream. And this is about taking large populations of information from large participant populations, or in some settings, this is about the computational work related to a population of cells. So we do realize that there's different definitions out there. But as the deans and as the president is focused on this, this is what they want to invest in the next phase of it to create some new energy in that area. And how is it different? You know, I'm an anesthesiologist on Wednesdays is what I tell people. The rest of the week I look like this. On Wednesdays, I've got a scrub cap on. This is called a late morning on those days. When I deliver care, typically, this is what I'm interacting with. I've got a patient and a medical record. That medical record might have some really cool tests in it, some really advanced science in it, but fundamentally, I'm interacting between a patient and their medical record. That is what we've delivered to the best of our ability to deliver great care. Who in here has had the flu shot this year? All right. And guess what the dose of that flu shot that you got was the same dose as the person next to you. And when we tell you, here's our medical advice to you, you should get the flu shot. And you is everybody. Maybe if you have a contraindication to it, maybe if your immune system is not as strong as it should be, you shouldn't get it. But unless you have a strong risk to it, our version of healthcare many times, and what I practice on a daily basis, every liver transplant I do always gets a general anesthetic and an arterial line. We do that for everybody. However, there may be some nuances that we need to work towards, which is, who in here has eyeglasses or contacts on right now? Yeah, that's actually a movement towards, based upon a test for you. We actually delivered a different therapy. We didn't just do a test to figure out whether or not you needed the therapy. We didn't just do a blood pressure check to decide whether or not you need blood pressure medications. We actually did a test on you, and then actually changed what therapy we gave you based upon the results of that test. And we've done that with genetics. The cancer center folks that are in the room right now, the genetics of either the tumor, the tumor cell, the patient itself, those are fundamentally altering the therapies we deliver to patients today. They go down completely different pathways. So there's some very exciting stories already in day-to-day clinical medicine where we're delivering precision medicine. What we're trying to do here is add to that. It's not about replacing it. It's not about decreasing the importance of what we're already doing. But the reality is that we need to bring in with the genetics other elements of lifestyle, other elements of socioeconomic status, other elements of the previous patients we've taken care of. So part of it is also, let's not just focus on the one-on-one interaction. Personalized healthcare is about a one-on-one interaction informed by many interactions before it. We don't want to depersonalize a one-on-one interaction, but at the same time, we must learn from our previous clinical care. We must learn from what we've already done in the past. And it's about adding to the arrows that we incorporate into our clinical decision-making process. As a medical industrial complex, we've done a very good job of looking at the medical phenotype. We do a decent job of asking about family history. I think it varies based on specialty and based on context. And we're doing an increasingly better job when it comes to the genetics element of it as well. Genetics is becoming part of our standard testing process, but we still only have 30, maybe 40 actionable germline mutations that we can work with. And more importantly, we actually don't know how to act upon them. They're actionable. That doesn't mean we're acting on them correctly or consistently or maybe in the most participant-focused way. We need to increase the clarity of the data from each of these existing arrows, and we need to bring in new types of data that we know our patients and our participants need us to do so. When I'm offering a patient a particular therapy, I need to incorporate into that thought process, what is their social situation? Do they have a support structure? If I'm offering a patient a surgical option versus a medical option, maybe the surgical option has high success rates, but only if you've got somebody at home that can help you for 6 weeks up and down the stairs with other tasks. How are we incorporating the life around them, the social situation around them? How are we incorporating their compliance, their ability to actually adhere to what we're asking them to do? How effectively are we aware of their past behavior and their past lifestyle, how active they've been? If we've got data from them showing that they're extremely active, maybe we can actually offer them a different therapy, trying to get them back to that baseline. And certainly, I know occasionally the city my patients are from. I'm pretty sure I don't know whether the part of the city they're from has a high pollution rate or a low pollution rate. I'm pretty sure I don't know the distance from their home to the nearest pharmacy or to the nearest grocery store that actually serves fresh groceries and fresh produce that can actually help them live that healthful lifestyle. We need to know these things about our participants because as we're learning, oftentimes those determinants of health are just as important as some of our historical biological determinants of health. And this is not about decreasing the importance of biology, it's about adding to the importance of biology. We are fundamentally still bringing all these different data streams together, but making it easier for you as either a researcher or a practicing clinician to do that integration across these existing data streams. There's 3 different elements to the activity. There's going to be a discovery element, and this is wherever you are. If you're a social scientist, this is the basic science of how you ask someone, are you depressed? Do you feel safe at home? There's great research being done in how to communicate with participants. That's the basic science in certain parts of our university, and we must encourage that, and we must fund that. It is also novel biologic therapeutics. It's finding new molecules. It's finding new genetic markers. It's finding new algorithms with artificial intelligence and deep learning to bring all that data together. As it turns out, some of those discoveries are actually things that we want to then try out. They're promising. They've been validated either in an animal model or in a focus group or in our subset population. We need to try it out in a larger, more representative population, and that's why the $3 billion healthcare system that we're sitting in right now is an amazing, underutilized resource. When we look at the number of our patients who are currently enrolled in the clinical trial or currently interacting with the College of Engineering or the School of Public Health or the School of Social Work and in real areas where ideas are being tested, we are underutilizing this resource, and we know from studies that our participants want to be more engaged in research, and we have infrastructure to help them to do that. We'll actually evaluate those treatments in the real world setting at the University of Michigan, and some of those treatments that turn out to be effective, we need to then go disseminate them. How do we make sure that a patient doesn't have to come to Ann Arbor to receive precision health? How do we make sure someone in Alpena is getting better health care because of what we're doing at the University of Michigan? The reality is, as a constitutionally defined entity, the state of Michigan's constitution created the University of Michigan. We have to be impacting the state of Michigan, not just Washtenaw County or the places that people have to drive in from. We have to disseminate what we find to be true. We have to evaluate what we find to be true at the University of Michigan. It may not work in Alpena, and we actually have to go try and learn there and change what we define as success. Parts of it involve population health management, and parts of it involve changing policies. It's amazing how often we find the right scientific answer, but we can't deliver the right scientific answer because the insurance company doesn't pay for it, or the FDA has a rule against it, or HHS has a privacy law against that. We need to define success not just as we found the right solution, we tested the right solution, we saw the right solution work, but what are we doing to actually disseminate the right solution? No one person can be doing all of this, right? No one researcher can be spanning all of this. And that's why the purpose of the Precision Health Initiative is to bring people from different disciplines, different parts of this process back together so that when someone's coming up with an idea, they're connected to someone at the other end. We've really evolved in how we think about this. When I was, presenting this, to be blunt, a year ago when the leaders of the university were evaluating this entire concept, we had this as a funnel. We had all these discoveries that then some of them work, and then it narrows down into treatments that are worth evaluating. And a few of those treatments work, and we have a few things that need to go get implemented. We realize this is not a funnel process. This is truly a virtuous circle. We're finding that public health and epidemiology is actually helping us define what we need to do basic discovery upon. We need to change our pipeline by connecting the pipeline as opposed to thinking it's a funnel itself. Is this a research thing? Yes, absolutely. We are going to be creating new knowledge. We're going to be enabling new research. We're going to make you more competitive for funding. We're going to give funding, and we're going to create new knowledge and publish that new knowledge across departments, across schools. Is this an education activity? Absolutely. This is about educating not only our students, but also our faculty, also the people going out to try and implement precision health and trying to implement new ways of thinking. So it ranges all the way from a graduate certificate program to how do we change how doctors, NPs, PAs, social workers talk to a participant when they're making a clinical decision. Is it a service activity? Absolutely. These are the three missions of the University of Michigan. We must be impacting those three missions. We must be out there creating platform that actually improves the health. 3 years from now, 5 years from now, we will be asked, did you impact all three of these areas? Therefore, we must invest in all three areas. That is how we're going to have to allocate our resources, and that's how we're going to allocate the work that we do here. We truly believe that all the way from discovery science, all the way to population health, the existing infrastructure at U of M is amazing. We need to build upon that infrastructure. Where we lack infrastructure, we need to create new infrastructure and connect. It is unbelievable when we go around and do these town halls, how many success stories we hear that we weren't aware of, that one of our jobs is going to be just connecting existing success stories to other success stories. And by no means do we think any one school, any one college, or any one department is the foundation of precision health at the University of Michigan. It is truly across all these areas. So what are we actually going to do? Lots of good PowerPoints is not success. We've got PowerPoints. We actually have to do something. You have to be able to tell what we're doing. We have to be able to succeed or fail. So there's 5 specific work streams with 5 specific budgets, leaders, and milestones. Some of those are established. We've got, as you can imagine, the near-term milestones. We had to commit to those with the leadership. We've started working on those already. But the ones 2-3 years out, we're going to learn from you. You're going to tell us how we're wrong. You're going to help us make small mistakes so that we have big successes. The 5 work streams are cohort development, which we could probably rephrase to something a little less biomedical sounding, to maybe community development or participant development. This is about sustaining, expanding not only the Michigan Genomics Initiative, which I'll speak to in just a moment, but also creating new communities of participants that are consented, enrolled, creating new data sets, exposing those data sets beyond where those data sets are currently available. It's amazing how much data we have that people don't use right now. It's amazing how difficult it is to get to data that people are trying to use. Breaking down those barriers, creating more usable data so that you as a scientist can be focused on doing things with the data as opposed to getting the data. That's a very important part of the workstream itself. The data analytics workstream is probably going to be one of the most reusable elements of this. As we go around, often as we find that the data that we've created or that we're planning on creating may not be of value to a specific researcher, but all the researchers say that when it comes to analytics, data storage, data management, they're all having challenges, whether you're working with a single cell analysis or whether you're working with a national reimbursement data set. You need a place to put that data. It needs to be secure, yet accessible across the university, and you like to make sure that that's, from your perspective, a commodity, not something you're spending meetings and meetings going to. So there's an entire data and analytics workstream with funded dollars to create storage solutions, analytics solutions, and reusable open source tools so that whether you're a biomedical scientist, a social scientist, or a health policy researcher, you have a similar place to go. We're going to create a watering hole that brings people together, and those work streams are dedicated to analytics and IT. Eric Mickelson, who's one of my colleagues and one of the co-directors, is helping out with that. He's the Associate Vice President for Advanced Research Computing, as I mentioned. Obviously, we have a lot to learn from what campus is doing in this area. There's another work stream called Health Implementation. It is surprising how difficult it is to take a great idea and try it out. It is depressing at times. Just a few weeks ago, I had received an email as a U of M faculty about our new Clostridium difficile risk score that we are now using at the University of Michigan. As it turns out, that Clostridium difficile risk score is great progress compared to where we were 2 years ago, but it is not informed by some of the great basic science occurring outside the School of Medicine. And that's because the barriers to implementing that were too high. So this is specifically about, number one, a decision support system layered on top of EPIC that allows us to use EPIC as the production version, but if we're trying a new decision, if we're trying a new randomization system, how do we make sure that we've got something that's research grade, not necessarily production grade, and allows us to innovate in a different way, allows us to be more flexible, and do something beyond a yes or a no, something beyond a risk score with real visualizations that are necessary to get providers to change their behavior. And then how do we actually take those decision support tools and when we find some of them work, to do the policy and dissemination work? A great example that we've seen is we know that it is better to actually do a genetics panel from a cost perspective and maybe from a patient perspective, and we're figuring that out, to do a SNP panel that gets 40 different SNPs as opposed to the 2 specific genetic polymorphisms that Blue Cross Blue Shield will pay us for. They'll pay us $200 for each of those two tests instead of paying us $300 for the 40 panel. How do we educate them about the fact that maybe that 40 panel is a more cost-effective measure if at the same time we're doing a good job of communicating that information effectively? That's what the Health Implementation Workstream is focused on, that decision support tool and the infrastructure to take it to actual implementation. We have an education and training work stream to build that curriculum, to build that graduate certificate course, to see if at some point we can have a degree program. And then on top of it, embedded within each of these, there are competitive dollars that will be going out for bid via a challenge grant system. There's new research. These are the platform pieces. Inside each of these platform pieces, there's research. And on top of it, there's challenge grants and some specific areas where we're investing based upon leadership's choices around what are specific areas that we must be investing in specific disease areas itself. One of those foundations that people may or may not be aware of is the Michigan Genomics Initiative. Who's aware of what the Michigan Genomics Initiative is? Okay, so this is a little bit better than when I go on campus. We're making progress at least. This is an initiative that's been going on for about 4 or 5 years now. We now have 50,000 patients consented, opted in, available for recontact, available for integrating the data set with the genetic analyses already performed upon their data set, upon their biosample. And we're now bringing in new data streams. As it turns out, it's still pretty hard to get to. And we know that. And the dollars are going into actually, how do I get to the genetic data? How do I connect that genetic data to actual clinical data that may be either in Epic or in other data sources. Who's aware of what data direct is? Good, we're definitely making progress. Who's used data direct? A similar number of hands. Okay, that's helpful. We realize there's limitations in data direct. We realize that from a performance perspective at times it takes too long. We realize there's data elements that are missing in there. We have to bring those data streams in so that the access to data does not become the obstacle to great science. And one major issue is that if you're outside the School of Medicine, if you don't have a level 2 login, you can't get access to either of these two resources easily. So as we talk about investments, many times you may want to be collaborating with someone outside the School of Medicine, but you can't because we built a structure and a set of policies preventing collaboration. One of the work efforts here is to fix that underlying issue. We are going to be investing dollars in changing the underlying community that we're enrolling via Michigan Genomics Initiative. We'll probably be renaming it because it's no longer a genomics initiative. It needs to be broader than that. We've heard that loud and clear. So one major issue is how do we continue to cost effectively recruit 10,000 patients, and what are the new technologies we need to understand the pollution level where that person lives, the access to certain resources where that person lives. How do we get to versions of that person that aren't in the electronic health record, that go beyond a paper survey? How do we get a survey out to them via a mobile health app that they answer every week, every month about how life is treating them and how they're feeling? We do know that we have to, at the very baseline, continue doing some things, which is continue a baseline recruitment rate, which is efficient, cost-effective in the perioperative area, but we must expand to clinic areas. We must expand to non-perioperative patients, and we must expand to pediatric patients. There's new work being done at the national level related to the ethics of recruiting pediatric patients. Do you reconsent at age 18? Whom do you consent? Whom do you tell the findings? We're going to be building upon some of that national work to have a focused area related to non-perioperative patients and to non-adult patient populations as well. As it turns out, the MGI patient population looks a lot like this room. This room does not look a lot like America, as it turns out, and we have to actively do things to change the scientific validity of the findings we are coming up with. We have a biased data set. We must change our biased data set. So we will be going to places that aren't like Ann Arbor in order to achieve those endpoints. So we already had some previous relationships set up with U of M Flint, U of M Dearborn, and some of the health systems there. So we'll be executing on one or two of those as part of the Michigan Genomics Initiative expansion. And then certainly, we've heard loud and clear that just being able to do DNA extraction and doing an Illumina chip array is not adequate for many of the researchers at the University of Michigan. So there might be some challenge grants related to what do we do on top of our existing data collection and on top of our existing biomedical analyses for a subset of those patients. And we've heard that loud and clear, and there's specific allocated dollars for that. Can we do it for all 10,000 patients per year? Absolutely not. Can we do it for a subset of those patients? Absolutely. Can we work with you to help you get external grant dollars to say, my incremental grant dollars are building upon this foundation, I'm just doing the extra $500 per participant for this test? Absolutely, and that's one of the key work streams, is to make you more competitive so that you're doing the incremental novel biomedical science, not the foundational find the patient work. Those partnerships with the community hospitals, community engagement with the School of Social Work, we're actually creating communities as opposed to cohorts. Those are the key things that can actually differentiate the University of Michigan, and we've already started working on some of those elements. The data analytics workstream is focused on making it so that it's easier for a University of Michigan faculty to be interacting with the Amazon Web Service, Google Cloud Platform, Microsoft Azure. We keep hearing that over and over again, but what we historically had is either an unknown pathway or explicit roadblocks in that pathway. We're taking those roadblocks away so that as your computational needs extend beyond what your local workstation can do, the public cloud is available to you. Just as importantly, having a private cloud, a computing resource at the University of Michigan, because oftentimes that's cheaper, safer, and might even be more effective because you can actually adjust that private cloud to your needs in an explicit way. So there will be dollars allocated so that you can be using a University of Michigan private cloud on campus, collaborating with your colleagues, and then at times you find that that's not adequate either from a performance perspective or certain tools, and we then might go out to the public cloud. Who heard about the recent Yottabyte announcement? All right, you're geeky, it's official. I like you already. So Yottabyte is a very exciting development here at the University of Michigan. We were gifted a platform, and then we built on top of that platform. It's a virtualization platform that actually allows you could be double clicking on your local workstation for SAS, or you double click on an icon like this, and the two look similar, except one of them has underneath it a terabyte of memory and a couple hundred gigabytes that are allocated just to you, as opposed to you having to run around and ask for little bits at a time. And the key is to make it in a way that you're comfortable with, that your staff are comfortable with. Oftentimes, our advanced options were things that weren't comfortable to either the medical community or to a particular analysis committee. This is about making it comfortable so that we're baby stepping ourselves into the future, as opposed to taking massive leaps at times. To be honest, we don't choose to take them. A lot of these tools have been available for the last 2-3 years. People haven't adopted them because they weren't comfortable and familiar. Yottabyte's really exciting because it's comfortable, familiar, but behind the scenes, it's amazing new technology. Certainly we know that there's no one right tool, so we're not going to tell you it has R. Well, it's got lots of things on it because we know everybody's got their tool of choice. Licensing limitations cause us to have some restrictions here, but fundamentally we know a variety of tools have to be available here, and we've got some of the experts to help evolve in those areas. We will be building upon tens of millions of dollars that have already been invested into the MIDAS initiative, building things like CSCAR, building things like ArcTS, so that we're not coming up with stuff de novo. Because at times, we're reinventing the wheel. Let's make sure we create new wheels instead of reinventing them. In particular, there's already a really impressive data science curriculum that's been curated by MIDAS. Let's take advantage of that and add on top of that for a Precision Health initiative. There's already work that's been done to break down some of the barriers when it comes to actually getting to Amazon Web Services and to the other clouds. So we're going to build upon the data science initiatives that work in there. One thing we were explicitly asked by the leadership was, please make sure that you don't build something and no one comes. Please make sure you don't build something just for the sake of building it and then stand back and admire, oh, that's an awesome building. We have to make sure this is of use. We have to make sure people are using it. That's how we are being measured, and that's how we're measuring ourselves. So they said, please go through and identify 4 or 5 specific use cases and talk to the researchers in those areas and see if what you're building will actually impact those researchers right now, right away, and consider our ability to actually fund incremental new science, transformative science, on top of what's already being done in 4 specific use case areas. And the 4 cases that were recommended to us were cancer, mental health, metabolic disease, things that are quite broad in their definition. And then, as we've learned now, a devastating public health issue, which is the opioid misuse crisis. 10 years ago, we weren't even talking about this, and we want to make sure that we're taking public health epidemiology lessons and informing our discovery. Opioid misuse defined relatively broadly is how we looked at it initially, and then our job was to go through with each of these, actually talk to researchers, make sure that the platform we're building helps their science and creates new science immediately. At that point, we actually worked with President Schlissel and the deans to say, okay, we want to fund 1 or more of these. How do you help us prioritize those? And the leadership, in particular President Schlissel, was very focused on focusing on the opioid misuse crisis. And the reason was he felt that it tested us in new ways. Although cancer, mental health, metabolic disease need investment, need additional investment, need new science, he felt that the gap between what we had historically invested and the gap between the tools we currently have available to address each of those areas, that gap was large in opioid misuse. He was particularly excited about it because the med school cannot alone solve the opioid misuse crisis. The College of Engineering cannot alone solve the opioid misuse crisis. All of these issues require collaboration, but he felt that the opioid misuse crisis in particular required collaboration and required us to be interacting with new parts of the university that we haven't had to historically. Current strategic efforts are all about, you have a chronic opioid user, there's opioid diversion occurring, going into the community, teenagers are getting into medicine cabinets, getting their first exposure to an opioid, going down the addiction and maybe the overdose pathway. What we really need to make sure is that we need to have a prevention strategy as well. How do we make it so that there's fewer opiates in circulation? How do we make it so that fewer people are exposed to opiates if they don't need to be exposed to opiates? How do we ensure that patients who are not on opioids stay not on opioids? So what we've started coming up with is the concept of a precision prevention strategy, as opposed to adding dollars on top of important, necessary, and already ongoing recovery strategies and management of existing chronic use strategies. And that's because we want to create an environment where we've got informed prescribing, personalized precision prescribing of opioids and other pain management strategies, taking into account not just the acute event itself, but also the environment around that individual. And the goal is to take opioid naive individuals and take this transition that often occurs into chronic opioid use and break that transition. Because that transition to chronic opioid use can oftentimes turn into abuse or overdose. And we see a lot of effort when it comes to public health measures in this area. As it turns out, the CDC, very important guidelines in opioid prescribing, are only focused on chronic pain. Once you're a chronic user of opiates, they've got strategies to help de-escalate that or change that. There's no guidance from the federal government or most specialty societies that is based upon data for the prevention strategy and how to prevent someone from becoming a chronic opioid user. We're filling that gap because that gap needs to be filled. The health implementation and education work streams, we're going to be working on how do we take our current 10,000 participants in MGI, expand that number, but also make it so that it's part of the clinical enterprise so that it's actually CLIA certified. So we actually return those results back to participants. And if specific clinicians want access to those results to make clinical decisions, you don't have to call that patient back for then a CLIA certified test. So a complete change of the purpose of that genetic testing. And certainly there's some very exciting areas related to pharmacogenomic drug development or pharmacogenomic recommendations. On the education and training pathway, we've got great leadership identified there to help identify not just certificates but also external partners that can show us how to do education, because as it turns out, at the med school, we're really good at graduate medical education. We're really good at figuring out how to teach a medical student. We don't really have a great structure around undergraduate education. We're learning about interprofessional education by going outside our four walls to learn this. How is this thing structured? So fundamentally, it is governed by an executive committee, the Precision Health Executive Committee, which is composed of the provost, Martin Filbert, and the deans of the founding schools, which is College of Engineering, School of Public Health, School of Medicine, College of Pharmacy. We've got 4 founding schools, and the provost, Martin Filbert, have gotten together and established an executive committee. That's who we report to. That's who is making our choices. Administratively, it's housed within Marshall Runge's office. Because it's not purely research, because it's not purely education, there's no other natural place. So it's living in a place that actually spans all of those areas. There's a faculty advisory committee, which will be composed of faculty across the campus to really inform the executive committee and the co-directors. And soon we'll have a national advisory board as well, just to get external perspectives on this. The funding, we've got about $40 million new dollars allocated to this initiative over the next 3 years. Of those $40 million, about 20% will be competitive challenge grants. About 80% will be platform building. Some of that is directed right now for the first 6 months or 12 months because we've had to execute on some strategies, but a lot of that is still in play and we're still learning how to allocate some of that 80% as well. After year 3, we've had commitments from the deans and from the provost that they will be supporting us in kind. So if we're able to get $5 million of external support, they'll be giving us $5 million of external support. And the fact that we've got a ramp after that as opposed to a cliff is very exciting to us, because sometimes the initiatives don't have that ramp, unfortunately. What's coming up next? We're going to continue doing outreach efforts like this. We're going to work with the workstream leaders, announce those workstream leaders, and announce those challenge grant opportunities. With that, I'll stop and hand over to Jenna, who's going to go through some of the examples that we've already seen of great precision health work that's occurring. And then we'll take questions right after that.
Thank you. Well, thank you, Sachin, for inviting me to come and speak this morning. I'm Jenna Wiens. I'm an assistant professor of computer science and engineering, and I lead the machine learning for data-driven decisions in healthcare lab. Our work aims to develop and use machine learning techniques to identify patterns in the vast amount of health data that we're collecting both inside and outside of the hospital today. We use machine learning to detect patterns, and then we can apply these patterns to future patients to help us sort them from low risk to high risk for a particular adverse outcome. We work across a number of different application areas. The work that's furthest along to date is our work in predicting infections with Clostridium difficile. So despite best efforts, C. diff remains stubbornly prevalent in hospitals, associated with excess medical costs of over $1 billion per year in the US. And we hypothesize that one of the reasons this is true is because we lack an effective clinical tool for measuring patient risk. So given that the disease risks are multifactorial, We take a data-centric approach to the problem, in which we leverage the contents of the electronic health record to build a model to identify which patients are at greatest risk of acquiring one of these nasty infections. Within the EHR, we have data pertaining to what medications the patient's on, to where the patient is in the hospital, and who's in the bed next to them. Now, in contrast to prior work in this area, we don't limit ourselves to a small number of known risk factors. We essentially throw everything in and consider the entire structured contents of the electronic health record. We also focus on making multiple predictions per patient over the course of the hospital admission, leveraging temporal trends in these data. And finally, instead of looking for that one-size-fits-all model, we're really focused on a hospital-specific approach, tailoring the model to the population to which we will apply it. So here at the University of Michigan, we leverage data pertaining to nearly 200,000 inpatient admissions, representing each admission as a high-dimensional feature vector of nearly 5,000 features per day. And we trained a model to identify which patients were at greatest risk of acquiring an infection with C. diff. Applied to a held-out data set from the most recent year, we achieved good discriminative performance, an AURC of 0.82, but more importantly, the model on average was able to predict high-risk patients 5 days in advance of sample collection. But we think we can do better. We're not stopping there. So through our work with our clinical collaborators, we've identified key characteristics that are necessary for the safe and meaningful adoption of these risk models. It's a given that the model needs to be accurate. The discriminative performance needs to be high, but the models must also be actionable, credible, and robust. So right now, we're working on ways to ensure that these models are actionable. So how are we doing that? Well, we know that a patient must be both susceptible and exposed to get an infection. Susceptibility is measured as a function of one's characteristics, what medications patient's on, other underlying disease. Exposure is typically measured as a function of the infection status of one's neighbors. But a few years ago, a study in the New England Journal of Medicine showed that nearly 50% of all C. diff infections were genetically distinct from other known infections in the hospital. So the question becomes, who's spreading the disease? We hypothesize that it may be asymptomatic or latent spreaders. To identify these latent spreaders, we represent the hospital as a network in which the nodes correspond to patients and the edges connecting nodes correspond to proximity. So two patients might share an edge if they share a healthcare worker or if they share a room. Then given this graph, we aim to infer which patients are most likely spreading the disease. And through this, we're able to better estimate exposure to the disease and better estimate risk of infection. So given the graph, we know who's connected to whom. We know who's infected, and then we've developed variational inference approaches to identify who's most likely spreading the disease. And this makes our model now more actionable than simply telling you who's at greatest risk. So with that, I'd like to acknowledge the students, the funding sources, and collaborators that make this work possible. I don't think that there's a single day that goes by where I don't meet with at least one of my clinical collaborators. They're so critical to the type of work that we do. And I feel very fortunate to be here at the University of Michigan, where there are so many wonderful engaged clinical researchers. And I'm very excited to be working with many of you going forward on the Precision Health Initiative. Thank you.
Questions?
This is very exciting. I'm in primary care, family medicine, as you know. And it's very different because we don't have a closed hospital space. If patients there for 3, 5, 10 days, we see them for 20 minutes, they're gone. And there's so many things we don't have control over once they leave the office. It's very complicated. How do you, I mean, I've been thinking about this in the past, but I'm just wondering, how do you or other people think about how we could start to incorporate some of this into that?
I think it's a great question. Number one, I'd love to hear from you on how you think we should answer that. But we think that the knowledge of what's happening before and after that visit is the first step. So one key thing we're doing is we're working on a mobile application that patient can choose to download or not download, that can start giving us information and that provider information about what life is like for them on a daily basis. So what we often see is that the interaction you have with the patient in the clinic that day represents certainly that day, but maybe the most recent week. It doesn't encapsulate the last 6 months that you've been interacting with that person. So wouldn't it be interesting to be able to tell how often they're leaving home for the last 6 months as opposed to what they're calling life is good right now? Wouldn't it be neat to be able to develop phenotypes of someone might be wandering towards depression because they're leaving home less often, walking less often, doing things like that. So number one, we think, is to learn about the patient outside just that clinic visit by gaining some data and some knowledge about it. I think on the implementation side, we'd sit down with you to say, what are the difficult choices you have right now that you need help with, that you're lacking either data, analytics, or resources to be actually making those choices? Is it about colon cancer risk stratification? Is it about telling the person whether or not to get a PSA test? What are the tough choices you have right now? And how do we take our health systems data and the literature to inform that interaction? So I'd love to sit down with primary care folks as well, and we're going to do so to say, what are your problems? Because this is not meant to be an acute care project. This is not, acute care happens to have a lot of data, but if anything, that outpatient setting needs the data more than other sources. That would be how we would handle that situation.
So my question is, if one's thinking about a project, who are the people who one approaches to discuss whether it fits into the construct which you've outlined?
Please email myself. You go to precisionhealth.umich.edu. Our contact information is on there. Rachel's contact info, Tina's contact info. There's an inbox in there. Contact us. We would love to engage with folks that have ideas, that as the challenge grant programs come out, there'll be formal announcements in those areas. But to be blunt, a lot of this is us also learning about what's already happening at U of M, because we may be going down a particular path and not even know someone's already doing it, which is not a shocking fact to anybody in this room. So at the very least, we'd love to hear from you. Email me for now, Sachin KH, S-A-C-H-I-N-K-H, but go to the website and you'll see my contact info as well. Yes?
Hi, Sachin. Donna Martin from Pediatric Genetics. 2 questions. The first is, how much thought has gone into the platforms that are used for genetic testing in patients? As you know, we have a very good molecular diagnostic lab that is CAP/CLIA certified that's doing panel testing and chromosomal microarrays. And currently, exome sequencing, which in pediatric genetics and other genetic services, we typically send to other hospitals. What efforts through Precision Health are being made to improve that pipeline and apply the genomic technologies in a clinical setting as opposed to SNP genotyping that is more of a research test? Can you comment on that?
That's a great question that you and Tom are asking.
Yes. Tom Giordano.
Significant thought has been put into 2 issues around that. Number one, how much of that is happening in-house, how much that needs to happen out-of-house, and what we can afford. And obviously that's why we've already met with the 2 of you, and we're going to continue meeting. So I actually met with the pathology chair, Chuck Parkos, to understand what are the opportunities in this area, because we do not believe that the future is doing what we've been doing for the last 5 years. We do not believe that everybody a SNP alone is the answer. We must be testing different, deeper sequencing, deeper genetic analysis, deeper other biologic analysis. So when I give this, when we have this conversation at other places, oftentimes the question is, what about the RNA? What about the microbiome? So there's other biologics, and we by no means think that SNP array is sufficient. We know for sure we can't do it for 10,000 patients per year. We know we must do it for more than 0. And so we're going to work with folks like you and with clinical leadership. So I've been meeting with Dr. Spollinger, Tim Johnson, to figure out, what does the enterprise want here? You know, what are they hearing? Where are we behind the competition in being able to offer that precision health billboard? What are some actionable things they want to be able to do, and how does this initiative help that? So we completely agree. We've got in-house skill sets there. We're going to use some of those, but we have to look to external skill sets too, if necessary. But you know that stuff better than we do. We're going to come to you to help us decide that. Okay. There will be dollars allocated for it, explicitly in the budget already, to do something deeper than just a SNP array.
Well, it's very exciting, and thanks for the work on this. My second question is, what is the time frame for the projects that you're anticipating rolling out? Do you have a rough estimate?
So there's an internal time frame that we are being measured by already. Our first big step, to be honest, is we've put together a set of work stream. I'm going to answer all the questions. Eric, what are we going to be doing in this area? When's our big next step? Eric Mickelson from the College of Engineering.
Our big next step is to announce these child grants opportunities. We're working very hard on the timeline. We're trying to coordinate this at this point with the deans. Very likely early next year we'll be rolling out a call for proposals, and very likely the proposals will come in two flavors. A smaller budget type of proposal, around 100K for fellows. B, proposals that target research on the order of 300 to 500K, preferably by teams that involve engineers, folks from the School of Public Health, and of course, folks from Michigan Medicine. So yeah, two types of proposals is what we're targeting right now. And again, we hope to roll it out in spring with anticipated start dates of September 18th. And then these programs likely will run in 2 years. They will end together with the 3-year anticipated running time of this effort.
There's also some work stream goals that are being established. We're presenting those to the executive committee in January to get sign off on who the leaders are and our year-by-year goals for those work streams, because that's when we can actually hit go. Yes.
Hi, I'm Sayoka Maroy in ophthalmology, and I've been in some email dialogues with you. One question in some surgical areas as far as some biobanking, and for example, in ophthalmology, we have some surgical specimens that are actually thrown away. Yeah. And so in looking at potentially epigenetics and tissues like that, have one question in relating to that and how that can be incorporated in relation to what, where this is going to.
I think it's very important to realize that gluing those two together is important. So we're already collecting the enterprise EHR. We may be already biosampling some of those patients for germline, right? Mm-hmm. The key for us is going to be, where is that biosample going right now? If that biosample is going to CBR, to the centralized biorepository, it becomes very easy for us to connect those two samples. It becomes very easy for us to connect the analytics. So we believe that there are strategies around existing ongoing biobanking efforts that we must connect to. We've heard from funders and from philanthropists that they want to see us doing more than germline in this area. I think our question would be to sit down with those who've got, there's probably 100 different mini biobanks out there right now, at least at the University of Michigan. We need to go to those individually, have them approach us. So as you've done already, unfortunately we didn't have dollars allocated historically, but now we might, to say, okay, you're collecting that piece, you're doing this with it. How do we inform that piece of tissue with this other data we're collecting and make that data set available, not just to you, but to some others. And what you get out of it is you get the rest of it for free. So that would be our mechanism, is to make sure that whatever we do exposes it to more individuals and more researchers, and exposes you and your colleagues to more research. But absolutely, we want to connect to non-blood tissue samples. One easy way to do that is if it's already in the central biorepository. So I think naturally those will be some of the first places we go to when we're already managing the biosample enterprise-wide. But that's not a requirement.
Okay. And then probably relevant to many of the people here in relation to those of us that are doing investigator-initiated R01s, and we have small-scale precision health type of things. Oftentimes when we put our budget in and for sequencing and all that kind of thing, is there a potential role with this rollout here as far as funds and doing that in-house here? And then having that strengthen our proposals when we submit it, said this is supported by, Michigan Precision Health.
Absolutely. That's explicitly one of the,
Well, that's a very good suggestion. I think that we really have to very carefully look into seeing how we can amplify your existing proposal efforts, yes, with the funds that currently are making available for this research.
Yeah, I'm doing my competing renewal next year, so that would be great.
Yeah, and part of it is just exposing what we already have available. Like on the website, here's the resources section you should copy and paste into your resources section. Here's a paragraph upon what data you get for free. Here's information about the array. If it's about sequencing, what we're learning now is there's a ton of cores that are available throughout campus that we don't know about. Those cores have started approaching us via these town halls, and we need to get those, and those cores have said, we exist, we need more business, please put us on your website so that researchers know we are available as a core. And just as we were speaking with Tom as well. So absolutely, and part of that is that amplification of existing efforts and integration. So absolutely, and there could be cost share built into that, absolutely. Where are we wrong? Where are you like, wow, I can't believe you guys didn't say blank. I thought this would be, It's okay, you can't hurt our feelings. We'd rather know now than later.
How many of you now have interactions, not with Jenna, but with other engineers and with other folks in social sciences and ISR? I don't know, how many of you do at this point? That's a good start. I think at the end of this initiative, we hope that the majority of you actually have these connections.
Yeah.
So for some low-hanging fruit on your educational mission, have you talked to residency program directors and departments and that as far as implementation into the curriculum directly?
Well, that's a great idea. We haven't yet. We've got the director of GME here today, as it works out. Perfect. So we just began that conversation now, it looks like. Dr. Bierman, who runs GME for the university, is here, so perfect.
So you mentioned that you're implementing precision health here at the medical center, but then you also mentioned that you wanted to implement it throughout the state. What does that sort of process in implementing it not only here at Michigan, but throughout the state look like?
So I think number one is we have to walk the talk here first. So we won't go to another hospital and say, here's how you do precision health, when at home we're not doing it. So number one is going to be us delivering on something at University of Michigan in this space where we feel it's worth us going out to help others with it. I'm not sure how many are aware. How many folks are involved in some of the Blue Cross Blue Shield collaborative quality initiatives right now? That's great. Good. That's a good sign that no one is, because that means there's an opportunity here. So as it turns out, U of M is the coordinating center for 17 CQIs, collaborative quality initiatives, where we work with hospitals throughout the state to implement best practice and learn what best practice is. It's not always a from U of M out phenomenon. Sometimes we learn from them and bring it in a peer-to-peer way. Those CQIs have allowed us to have legal, so we have a BAA with every single hospital in the state of Michigan, as it turns out. Data, we're actually getting data from 84 hospitals and hundreds of practices throughout the state of Michigan. So the thought would be we build upon some of those existing relationships and see where lessons that we've learned from those relationships can actually be used to go out. So it would be something like, if we come up with a better way to prevent C. diff, right? To detect C. diff five days in advance. We're not going to be writing that decision support platform, so it can only be used at University of Michigan. The software that we're using for that, we'll be using industry standards, ONC approved, FHIR standards, smart apps that you can bolt on top of any Epic hospital or any Cerner hospital. That fundamentally is one important thing we're doing, is that when we design things at the beginning, we're thinking about a non-University of Michigan end, because oftentimes we don't, because it's hard to do that. So that's number one, is I think making sure that the tools we develop are actually re-implementable. Second is to take these existing networks and take leadership and lessons learned from those networks and apply it to precision health. So there'll be leaders from some of those initiatives involved in precision health. Great question. Anything else? Well, hopefully this has stewed up some thoughts. It's meant to be the beginning of communication, not the end by any means, so look forward to hearing more from you. Thank you very much. We'll be here for a little bit answering questions. Thanks for taking time watching Precision Health at the University of Michigan. If you'd like to learn more, please go to our website, precisionhealth.umich.edu.